What I'd like to do today is share some of the experience that we've had in Philadelphia in the United States regarding surgical site infections. And listening to the lectures today, it certainly appears that in Europe you're under as much pressure as we are in the U.S. to try and reduce surgical site infections related to total joint replacement. In fact, in the U.S., surgical site infections have been now considered what is called a zero event. And by being a zero event, that means that it should never occur, at least in terms of the payer's eyes, the people who are paying for the surgery. It should be a zero event. And in the very near future, when we have an infection, there will be no additional payments to clean up or repair the infection. So as we all know, infection is a very costly complication, and there will be no additional funds to cover that complication. The original surgical fee will have to take care of it. So the onus is now on us in the U.S. to reduce surgical site infection to zero, which is certainly a very, very formidable task. So I'm going to talk to you a little bit today about an approach that we developed at one of the hospitals that I work with. I'm a part of a group of 150 orthopedic surgeons. The group has 17 total joint surgeons. We do over 10,000 joints a year in the Philadelphia area, and we operate out of 12 different hospitals. And one of the hospitals that I work at decided about 4 years ago, anticipating the future, that we are going to be tasked with a zero infection rate, to start an infection program to reduce our infection rate to zero. And so we decided to use a multimodal evidence-based approach for this problem. Now, I was very interested in some of the talks earlier because it sounds like the infection rates in the U.S. and in Europe are similar, at least the baseline numbers. And we did a study a few years ago where we looked at a nationwide inpatient sample database from 2001 to 2009 and found out that our infection rates after total joint replacement are 2% to 2.4%, which is again reflective of some of the speakers who said that if you do enough of these cases, you will see infections. And we know that it leads to tremendous morbidity and mortality. There's no question that once a patient has an infection, the results are severely compromised. They're never as good as the primary joint could have been. There's always a significant reduction in function, and often the patients are left with chronic residual pain. Moreover, it's an extremely demoralizing complication for us as surgeons. Certainly in the U.S., where it's soon to become a never event, it has significant financial implications. There's no additional reimbursement for extra care. And if you look at the monetary cost of these complications in the U.S., because of the enormous volume of cases that we're doing, you can see these numbers, which are absolutely staggering, that the cost for infections without us doing something, and this is with us staying at the 2 to 2.4% infection rate, we could be spending up to $1.62 billion a year in the U.S. just to treat infections related to total joint replacement. So in the U.S., everybody refers to our new health care legislation as Obamacare. It's also called the Affordable Care Act. But one of the things that's very important is part of Obamacare, or the Affordable Care Act, is going to make infection data transparent. So my numbers, my specific infection numbers and my hospital infection numbers will be published on the internet, and I'm not sure if that situation is in Europe now or you're coming to this, but any patient will be able to simply turn on their computer and look up what my infection rates are and compare them to other doctors. So there's an enormous effect certainly there too for us. So we decided to develop this multimodal approach. With this multimodal approach, we based it on the concept that we know multimodal approaches have been very effective for VTE prophylaxis. They're extremely effective for postoperative pain management, accelerated rehabilitation, and we felt there was ample evidence to support this multimodal approach for reducing PPI. So with this multimodal approach, and I'll sort of cut to the chase right at the beginning, I'll tell you what happened from 2008 until today, and then I'll explain how we got there. In 2008, at this particular hospital, one of the 10 hospitals we work out of, our infection rate for total joints was about the national average, 1.9%. With the multimodal approach, we've reduced our infection rate today to 0.2%. So I'll go through how we ended up getting to this point. First of all, our baseline prevention strategies were probably similar to what most surgeons in this room certainly adhere to. In our particular instance, we used body exhaust suits. We did 24 hours of prophylaxis with first-generation cephalosporin, at least when indicated. And then we had dedicated surgical teams and very expeditious surgery. It's not uncommon for us to do 12, 13, 14 joints a day in some of our busy surgical suites. And so you can imagine our surgical times are fairly quick. And that certainly should reduce infection rates. But even with that speedy surgery, even with that fast surgery, we were still having about a 2% infection rate, which was very concerning. So the first step we did was to first form an infection reduction committee, which consisted of all the key people in the hospital, including infection control nurses, surgeon administrators to look at cost, physicians, OR personnel. And we did a assessment of what our current situation was. As mentioned earlier, OR traffic is a big problem. We monitored that and found out immediately that we had a very big OR traffic problem, and then did no non-essential people in the OR, no non-essential team breaks, which we just saw earlier, leads to a high risk or increases the risk of infection. Even we have a lot of visitors in our ORs. A lot of people come to observe, and so we decided to start having visitors wear body exhaust suits, particularly if they were going to be coming close to the wound or hanging over the wound. We added much more equipment to the room, so we didn't have to have as many people going in and out of the room to get different types of equipment. And then we went over our entire central processing process and re-emphasized the importance of appropriate cleaning and sterility of instruments. So that was step one. Step two, right around this time, in 2008, I was introduced to this particular dressing. There were certain features of this dressing that appealed to me. It's certainly the fact that it's sealed by Duoderm was attractive because many dressings, I think, do leak and have problems. I leave the dressing on for a period of 5 days, and I believe the barrier prevents wound contamination. Historically, before we started using this dressing, we were removing the dressings daily. They were being changed by nurses. And interestingly, we had several patients, when we started reviewing our data, that became infected with very odd organisms like Proteus, Serratia, things that the patient clearly were not getting in the OR. These are organisms that the patient was picking up on the orthopedic floor. And we felt that if we could keep that dressing sealed, we may be able to create a barrier and seal out some of these unusual bugs that patients pick up when they're up on the orthopedic floor. In addition, the antimicrobial environment created by the silver impregnation was attractive, and we thought the cost was reasonable, certainly to do a trial of the product, considering the cost in the U.S. of cleaning up a periprosthetic infection ranges anywhere from $50,000 to $100,000 US. So this is a study that we will be soon publishing. We looked at 1,892 patients undergoing primary joint arthroplasty between April of 2009 and March of 2012. And during that period of time, one half of the patients were matched to patients who had a sealed dressing versus those that did not have the sealed. They had the standard dressing. And when we compared the standard gauze dressing to the AQUACEL dressing, we found a reduction in infection rate from 1.8 to 0.4%. Because this is a retrospective study and it went on over a long period of time, we recently conducted an evaluation, a chart review. I had one of my research fellows review every one of these charts and then did statistical analysis with multivariate analysis to make sure there were not other complicating factors. The other factors were not significant, and we soon will be submitting this paper to Clinical Orthopedics and Related Research for publication. So let's talk about some other strategies also. First of all, postoperative bleeding. There's no question the more postoperative bleeding that is present, this does increase the risk of infection. In this particular paper that was published recently by myself and Dr. Parvizi and Dr. Rothman showed that patients who had excessive anticoagulation after surgery, those who had higher INRs if they were on Coumadin, patients who received low molecular weight heparin versus those that could be treated with aspirin had a substantially higher infection rate. And so we strongly believe that strategies that reduce postoperative bleeding are very important for reducing the risk of infection. Simultaneous with this, an additional study was published, not by our group, but by another group in the U.S., that showed that aspirin was extremely effective for reducing thromboembolism after total knee arthroplasty. And you can certainly see from these numbers that the results were comparable to low molecular weight injectable heparins, and also comparable to warfarin. So based on this, we now have a very high threshold for doing prophylaxis after surgery with any agent other than aspirin, although in high-risk patients, we still do occasionally use some of these other agents. Additionally, to reduce bleeding, a couple years ago, we started widely adopting the use of tranexamic acid after certain data was published. There's now several good level 1 studies. In fact, we're adding an additional one to the literature this year on bilateral total knee replacement. But we were able to show significant bleeding reduction with the use of tranexamic acid and no increase in venous thrombosis. So very, very important data and a great way to reduce bleeding both with total hip and total knee replacement. And if you look at our own data, and this is the data that we will be publishing this year for bilateral knee replacement, we showed that we were able to reduce our transfusion rate after bilateral total knee arthroplasty from 50% to 11% of patients with no increased risk in DVT or in VTE after the treatment with tranexamic acid. Well, how about preoperative antimicrobial decolonization? We did talk about that earlier, and it is very, very important. In our particular practice, we prescribe nasal decolonization for every single patient. And the reason we do that, it's somewhat controversial, the reason we do that is because screening programs, particularly in really high volume practices, can be very cumbersome and prone to clerical errors. A patient can have a positive culture result, and in a very high volume practice, you can miss that positive result. And so we felt that it was more appropriate to simply use this prophylaxis measure in every single patient. We do chlorhexidine wipes for 3 days before surgery, and there is data out there that shows that this does reduce the rates of infection substantially. This is Dr. Michael Mont's data out of Baltimore, showing that he had substantial reduction with skin decolonization using chlorhexidine wipes. One of the things, just an aside, I know we talk about dental clearance all the time, and really, historically, there's a lot of anecdotal evidence that we should be doing dental clearance, but we recently just published a study showing that dental clearance may not be that important. Certainly not as important as doing some of these other things like skin decolonization. Skin decolonization may be more important than getting dental clearance. Another very, very interesting study that we just published also at our institution is combining preoperative prophylaxis with a first-generation cephalosporin and vancomycin. And I know in the U.S. we have a bigger problem with MRSA than here, but we have a very big problem in the U.S. with it. This is not that controversial. For us to do certain things, we have to meet what are called SCIP guidelines. These are surgical compliance guidelines that are consistent with what are considered best practices, and it has been approved for us to use this combination of antibiotics. And the study that we published was published by one of my partners, Eric Smith. He showed that in his particular group, he was able to decrease his incidence of PPI using this combination of antibiotics from 1% to 0.5%. But very importantly, he decreased his MRSA infection rate from 21 to 14%. And this is a very interesting sidebar from this study, but this is very important. His rate of success when he found an infection and brought the patients back to the operating room became much higher with the combined antibiotics, because we felt we were getting infections with organisms that were less virulent, and he was able to increase his success rates from about 22% to 76% or 77% with just a simple incision and drainage when he combined the antibiotics. So we believe that this is also important. Also, as mentioned earlier, I think the data now is absolutely conclusive that we should be irrigating our wounds with dilute betadine prior to closure. A wound irrigation for approximately 3 minutes with a very dilute betadine solution in the Chicago study, and then we also confirmed this because we work closely with the Chicago group, reduced infection rates from about 1%, six-fold reduction down to 0.15%. So another measure that we should be combining. We also have a few other things that we recently started. Diabetes in the U.S., non-insulin dependent diabetes related to obesity and poor diet is an enormous problem. As you've probably read, probably now about 20% of Americans are diabetics. And we now postpone surgery if the hemoglobin A1C is greater than 7. If a patient has a BMI greater than 40, the surgery cannot be considered elective, and certainly some patients are so crippled that even when their BMIs are above 40, you have to do their surgery because they just can't walk, and obviously that's not something that we can ignore, so that's not really elective surgery, but if they're still functional, we will not do their surgery until they lose the weight. And we've been adding vancomycin to Palico cement when we do use cement. And we use the vancomycin over some of the other standard antibiotic cements. So again, why do we use the vancomycin? Well, in our particular situation in the U.S., the only antibiotic that's been approved for mixing, preoperatively mixing with the cement is tobramycin, and we did not feel tobramycin was very effective. Vancomycin has a much better antimicrobial spectrum, and there now are mixing systems available to facilitate mixing the vancomycin in there. So in summary, we did a multimodal approach to PPI reduction. First of all, it requires a certain focus on the problem, and you need to carefully evaluate your current practice to see what you're doing. We then employed the enhanced antimicrobial dressing, which we found to be very effective. We developed strategies to reduce postoperative bleeding. We instituted a pre-op antimicrobial decolonization program. Step 5 was pre-op antibiotic prophylaxis with both cephalosporin and vancomycin. Step 6, we started using dilute betadine. And finally, we decided to institute a policy where we correct high-risk creating conditions prior to elective total joint replacement and use of vancomycin PMMA when appropriate. In summary, it's always been considered a bad complication. Nobody wants infection, but in the U.S., and I'm sure you're under the same pressure we are to reduce this complication, it is the new healthcare laws have made PPI very, very onerous, and a multimodal approach to PPI certainly seems logical. In our particular situation, we were able to reduce our infection rate tenfold, which had a very high level of significance. So hopefully this is the end of PPI, but I'm sure there's some patients that will always have this dreaded complication, but we've done a great job of reducing the incidence substantially. Thank you.